Hello, I'm Dr. Wendy Cole. I'm the Director of Wound Care Research at Kent State University College of Podiatric Medicine. And today I'm going to briefly discuss my new published manuscript in the Journal of Wound Care that details the use of bacterial fluorescence imaging to target wound debridement and accelerate wound healing. We know that high bacterial loads, greater than 10 to the fourth colony-forming units, delay wound healing. Optimal wound bed preparation, consisting of debridement, control of infection, exudate management, are very important to help establish a balanced healing wound environment. Fluorescence imaging of bacteria via the MolecuLight imaging device can provide immediate information on the presence and location of pathologic levels of bacteria on the wound and its surrounding tissue. The device is very easy to use. It's portable. It's about the size of a cell phone. It's non-contact and it is non-invasive. It simply uses a safe violet light to fluoresce bacteria on the surface of wounds and the surrounding tissues. In this 12-week prospective observational study, we evaluated the use of fluorescence imaging to detect bacterial burden in and around the wounds, measure the wound area over time, and also to guide debridement based on the location and the extent of bacteria that we saw on the fluorescence images. All patients enrolled in the study were 18 years of age or older, and they had chronic non-healing lower extremity wounds of at least 4 weeks in length. They were all already established patients within my practice that had not entered into a healing trajectory. 11 patients with these lower extremity ulcers were imaged weekly, up to 12 weeks or until healing, whichever occurred first. Weekly assessments include clinical signs and symptoms of infection, standard wound images, as well as wound measurements, fluorescence images, and then target debridement based on those images as needed. So here we're going to take a look at a couple of different images from the study taken with the MolecuLight device. The standard image, as you can see, we have wound stickers that we place on the wound, and the device automatically is able to detect the perimeter of the wound and measure length and width and wound area. And then we switch it to the fluorescent mode, and the violet light then is able to fluoresce the bacteria. We see porphyrin-producing bacteria will fluoresce or emit a red or pink fluorescence, and then Pseudomonas uniquely fluoresces cyan. We were able to use this information to make a decision tree based on what we saw on those fluorescent images. And we evaluated the wounds. If they had no devitalized tissue, we then obtained a fluorescent image. If the wounds were fluorescent negative, did not have any levels of pathologic bacteria noted, we simply went on to dressing selection. If the patient did have fluorescence bacteria noted in the imaging, we move them into the debridement arm. If patients had any kind of devitalized tissues, hyperkeratotic tissue, slough, or necrosis, they had a wound debridement, and then we took a fluorescent image. And based on those fluorescent images, we were able to determine if additional debridement was needed to help to rid the wound surface of any pathologic bacteria. And if we weren't able to completely rid the wound of fluorescence bacteria with debridement, then we were able to determine the best dressing selection, possibly topical antimicrobial therapy or even oral antimicrobial therapy based on those images. So as mentioned previously, all wounds in the study were on the non-healing trajectory, and the average duration of the patient wounds were about 16.5 weeks. So these were chronic, recalcitrant, hard to heal wounds. Upon initial assessment, 10 of the 11 wounds were positive for bacterial fluorescence. Fluorescence imaging also helped to support the medical necessity for debridements and additional debridements, and also dressing selection. It was only when bacterial fluorescence was eradicated that the wound area began to decrease. So interestingly enough, when the wounds had presence of bacterial fluorescence, we saw weekly wound increase on average of about 6% in area. But once we eliminated that bacterial fluorescence, we saw a decrease in wound area of 27.7%. So all wounds that had a fluorescent signal that was eradicated went on to healing in an average of 2 to 6 weeks. Here's a couple examples of patients that were enrolled in the study. And this particular patient had a trauma wound of the lower extremity that again was recalcitrant. Upon initial evaluation, we can see some red and pink fluorescence in the wound in the peri-wound area. So we began her on a regimen of a topical antimicrobial dressing. By visit 5, the wound had been progressing well in area, but then kind of blew up in measurements. And then we took the fluorescence image and we can see this starburst appearance around the peri-wound tissue. And we read this to really indicate an early sign of cellulitis. So I started her on oral antibiotic therapy, and within the next week, you can see from the fluorescence image that peri-wound inflammation and that starburst appearance had decreased or almost been eliminated. So we think that we were able to detect the cellulitis before really any clinical signs of infection were present, and hopefully prevent the patient from a long treatment course of oral or IV antibiotics or even a hospital stay. Here's another patient that was part of the study. And this wound was also due to a traumatic incident, and it had been fairly recalcitrant. It opened for 13 weeks at this point in time. You can see there's a large amount of devitalized tissue, and upon initial intake, when we did the fluorescence imaging prior to debridement, the area really does light up with both cyan and red appearance of the tissue. I did a really good thorough debridement, but unfortunately, even post-debridement, our fluorescence images were still positive. So we started him on a treatment regimen of topical antimicrobial dressings. And by week 5, prior to debridement, we do see a slight bit of cyan that fluoresces in the wound, but post-debridement at visit 5, there is no fluorescence able to be detected in the wound. And this patient actually rapidly went on to a healing trajectory after this visit. So in conclusion, early detection and ongoing monitoring of bacterial burden can help to facilitate wound healing. And incorporating the MolecuLight as a point-of-care fluorescence imaging device that could help to detect bacteria into our standard wound assessment can help us with informed location and extent of bacterial burden to guide our debridement. It can support our clinical decision-making with dressing selection, and also aid to determine if we need any topical or oral antimicrobial therapy. And again, really the take-home of this study was none of these wounds went onto a healing trajectory until we eradicated that fluorescence bacteria, that pathologic level of bacteria in the surface of the tissues. So in conclusion, I just want to thank you for taking a look at this brief synopsis, and I hope you go to the Journal of Wound Care for the complete document. But here's my information if you'd like to contact me. I'd be happy to answer any questions. Thank you very much.